who's here. You're looking at the hardcore SIAers right here. This is the ones that really want to learn, or really want to engage with the community. And speaking of one to learn from, I want to introduce Dr. DeFronzo, aka Mr. Diabetes, aka World Traveler, and he's been everywhere. And we welcome again to the Summer Student Aging.
Make sure it's turned on.
AKA not moving very fast. Unfortunately. Can you hear me okay?
Yes.
Okay, so I'm going to stand in front. So I guess the last hour Nick told you how to treat type 2 diabetes. So in this hour, I'm going to tell you how you can get rid of Nick so you don't have to treat type 2 diabetes. No, we don't want to get rid of Nick. We can't have two geriatric catastrophes. One Sunday paper followed by the next Sunday paper. We need Nick around, okay? So I'm going to talk about prevention of type 2 diabetes, and I'm going to spend a fair amount of time going through both lifestyle intervention, which generally does not work. Sorry for the nurses and nurse educators and dietitians, but we have to now start to face facts as opposed to fiction and what's in your mind. And I'm going to talk a lot about pharmacologic therapy. So, Nick probably showed you this slide, and I'm not going to go through it in great detail. But there are a lot of people in the United States, basically what this says, who have type 2 diabetes. For every person with type 2 diabetes, there are at least 2 people with, quote, pre-diabetes. And we know that this epidemic of diabetes is being driven by the epidemic of obesity. And diabetes is very, very costly. And the cost goes not just with the treatment of the disease, but the long-term micro and macrovascular complications. And what I think is also less appreciated is that obesity itself is associated with a whole host of comorbidities, which are difficult to treat, costly, and decrease the quality of life, independent of whether the patient is going to develop diabetes. And since obesity is the forerunner for diabetes, it's also the forerunner for pre-diabetes, which means that there are a couple of ways that we can intervene. One is to get people to lose weight, and I will show you that if you can get people to do it, it's very effective. The issue is not whether it works or it doesn't work, it's whether can you get people to stick to it on a long-term basis. And the cost of treating people with type 2 diabetes in the United States is in excess of $100 billion, and it's about 10% of the entire healthcare budget, and it's only going to go up with time because we're experiencing more and more people with type 2 diabetes. Now, if you are taking care of diabetic patients, I think we all recognize that the microvascular complications are related to 2 factors. Number one, how high your glucose is and how long your blood sugar level has been elevated. The macrovascular complications are very weakly related to your A1C and glycemic control. So blood pressure and lipids are much, much, much more important for the macrovascular complications. But since the microvascular complications are related to your level of glycemic control, what that says is that if you don't let the A1C and glucose go up, you should be able to prevent the microvascular complications. So we break down the cost, okay? About 1/3 is the macrovascular complications, which is going to respond in a really small way to glycemic control. 1/3 is the microvascular complications, which, quite frankly, should be totally preventable. And studies have shown if you don't let the A1C go up, and then the other 1/3 is related to a whole host of other factors. So it makes sense to me that if we start early in the natural history of the disease, at the pre-diabetic stage, and you maintain the level of glycemia such that the A1C doesn't exceed 6.5%, you should be able to completely prevent the microvascular complications. And if you don't believe that, then you just simply should not be taking care of diabetic patients. And you simply are not aware of what's in the literature, as we know from the DCCT trial in type 1, United Kingdom prospective diabetes trial in type 2s, that if you control the glucose, you will prevent the microvascular complications. So, the gist of what I'm going to go over is why we should use pharmacologic therapy early on in the natural history of the disease, even though, and I emphasize this, there are no drugs approved in the United States for the treatment of prediabetes. So if we're going to use pharmacologic therapy, which I do advocate, then it's all going to be off-label use of the drugs, since there are no drugs approved. So why should we use pharmacologic therapy? And the answer is really very simple. Diet and exercise simply do not work. And any of you who think that it's going to work in the majority of patients on a long-term basis are totally delusional and totally unaware of what's in the literature. And even the people in the obesity field don't believe that this is going to work. And you'll see as I go through this why it's virtually impossible that diet and exercise alone, without some kind of pharmacologic therapy, is going to work. So, there have been a number of meta-analyses that they've carried out. The first one was done by Anderson in 2001, and there were 26 of these, quote, randomized trials that he looked at, and what the trial showed was that while you're in the trial in the first year, you're actually very good at losing weight. And then once you're out of the trial in the second year, you regain 75% of the weight that you lost. So, lest you think we're doing better, Danziger in 2007 updated this earlier meta-analysis. So now he looked at some 46 meta-analyses, basically came to the same conclusion. And unless you think something has changed since 2007, the Cochrane analysis of 2013 has come to the same conclusion. While you're in the program, you do very well. Once you get out of the program, things start to slip, even though they're, and I will show you with the UKPD, with the diabetes prevention program, even though there's fairly intensive intervention after the program is over, you'll see that people just gradually regain the weight. And if you still don't believe it, the look-ahead trial was stopped, okay, because it didn't work. So the look-ahead trial first was a big NIH-sponsored trial, millions and millions of wasted money, quite frankly, in a trial that had no chance of being successful. And the outcome was to show that diet and exercise would, lifestyle intervention, prevent cardiovascular disease. So after 5 years, the trial was completely negative in terms of cardiovascular disease. And so the outside review panel said, you can carry this study on for 20 years and it's never going to be significant. So we recommend you stop the study, and the study was stopped. And people, the investigators, start to look for the benefits, okay, in other areas. So this is what they claimed was, quote, a benefit. I'll let you make up your own mind. Now remember, hundreds of millions of dollars have been spent on this study. So if we look at weight loss at year 1 and year 4, now they're in the study, and they're being intensively treated. So the first year, people do very, very, very well. They lose 8.6% of their body weight. That's actually fantastic. By year 4, while they're actively in the trial, they've regained half of the weight. Okay? They're not out of the trial yet. When the trial ends, all studies have shown the weight gain comes back very quickly. So any remission, okay, any remission being defined as a reduction in any diabetic medication, stopping of any diabetic medication, or a drop in the A1C that's greater than 0.3%. 12% of the people in year 1, 7.3% of the people in year 4. That's absolutely pathetic. I mean, why these people would write that this is something that's good is beyond me, and why the editors would let this get published with the tone that's in it. And if you look at complete remissions, it's less than 1% at the end of 4 years. And my interpretation of this paper would be the exact opposite of the title, is that it's a total failure. And if this is what you're going to achieve, you're not going to achieve very much. And at the end of 4 years, complete remission is seen in 1% of the people. I can dwarf that with drug therapy, okay? The data, for any of you who believe that lifestyle alone is going to prevent diabetes or treat diabetes, it just simply is not there. So I'm going to take you now to the diabetes prevention program, which is the study that's always quoted as showing that, that lifestyle intervention effectively prevents the development of type 2 diabetes. So this is a study done in people with impaired glucose tolerance. IGT, the diagnosis is made on the basis of the oral glucose tolerance test. So if I give you 75 grams of glucose to drink, and your 2-hour glucose gets to 200, you have diabetes. It's less than 140, you're normal. So if you're in that range of 140 to 199, you have impaired glucose tolerance, pre-diabetes, okay? So these people, male, are, and they're about 40, there's a fourth arm, but that brings the total number of people up to about 4,000. But I'm just going to go through the first 3 arms. Intensive lifestyle change, I'll show you what this was in a moment. Standard lifestyle change, sometimes people call it lifestyle life, and metformin. And then the people are going to be followed up for 3 years. So if you look at the end of 3 years, diet and exercise, while they're in the program and they're actively being followed, works. Okay? The issue is not whether diet exercise works or doesn't work. It for sure works. There's a 60% decrease in the conversion rate of IGT to type 2 diabetes. The problem is what happens when you get out of the program. Okay? And metformin, which is a medication that's fairly cheap, was half as effective. So everybody touts DPP, okay, and forgetting all the other literature that I showed you as being effective, okay? Now, in the DPP, there was a fourth drug, and the fourth drug was troglitazone. Troglitazone, as you know, was removed from the U.S. marketplace because it caused severe liver toxicity. Troglitazone was in the DPP for 1.5 years, and then it was taken out. So what the investigators did is they said, let's just look at what happened in the first 1.5 years. And many of the people weren't even on troglitazone for 1.5 years. That was just the longest anybody was on it. So if you look at now the number of cases per 100 patient treatment years, the best therapy was actually troglitazone. The next best therapy was lifestyle heavy. Metformin, now when you express the data this way, is not too much different than lifestyle heavy. And the worst therapy was lifestyle light. Okay, so what is this? This is what most of our physicians in the real world tell our patients. Okay, in fact, this is more than what most of the physicians tell patients. And I can tell you, unless physicians are a lot more knowledgeable than I am, they don't have any idea how to counsel patients about starting on an exercise program or what kind of appropriate diet they should be on. And they don't have the resources of sending the patient to a dietitian or to an exercise therapist, nor do they have the time when GPs are seeing patients every 10 to 12 minutes. So even worse is the fact that they're not knowledgeable, they don't have the time, and patients can't stick to a diet even when they're intensively in the program. Okay? So here's what happened in the diabetes prevention. This is what really happened. Okay? So if you look at the change in the weight in the placebo group, of course nothing happened. That's lifestyle life. Metformin is an anorectic molecule and sometimes causes some GI side effects. So they lose about 2.5 kilos. Okay? So this is what happened in the DPP. So in the first 6 months, year, it works very well. And you see them gaining back the weight even when they're in the study. Okay? Now, there's this continuation phase that's called the DPP overlap study. Okay? And I'll tell you exactly what was involved in the innovation here and there. But you can see once they're out of the study, even though this is pretty intensive, you'll see, they gain back all of the weight. They come back to where what metformin does. Okay? So, what was in this trial? Okay? 16 sessions, okay, at the beginning when you come into the DPP, taught by case managers on a one-to-one basis. Remember, there are 4,000 people in this study. Okay, 1,000, about 1,200 people in each arm. Okay, so over the first 24 weeks, this is pretty intense. This is beyond anything that we could ever do in a real life situation. After that, they had one-on-one sessions as per the subject required, and then they had regular group sessions to reinforce the behavioral changes. They had their own individual physical therapist who did one-on-one workouts with them, okay? If you could not afford to go to the gym, they paid for the gym, okay? If you could not afford the taxi to get to the gym, they paid for the taxi to get to the gym, okay? So this is not some simple intervention. This is pretty heroic, way beyond anything that could ever happen in real life. Then at the end of 3.2 years, the official part of the DPP was stopped, and then they went over to what they called HELP. So HELP was initiated with 16 more one-on-one sessions, and then group sessions after that. And you can see that once they got out of that really intensive period, even though they were having one-on-one sessions, that people still gained back most of the weight. And then this is what you don't see. It's in small print, and everybody wants to forget, okay? Half of the people actually who were very good at losing weight still went on to develop diabetes. So what this says is that even if you lose the weight, you have the 50% chance of progressing to diabetes. So those odds are not very good to me, okay? So I would opt for something else. I would opt for pharmacological therapy. Now, people tried in other countries to take the diabetes prevention program and to develop it into a real-life situation that you might be able to promote on a national basis. So this is a group in Finland who took, there was also a Finnish diabetes prevention program, the results of which were very similar to the US program, very intensive, very similar results. And in this study, they took 10,000 people who were at high risk for developing diabetes. It's called the Finn Diabetes Risk Study. Okay? And these individuals had, there could be individualized counseling, but most of it was group counseling based on the Finnish diabetes prevention study, which, as I said, is very similar to the US prevention study. It's basically diet and exercise. Now, what happened in this study? Okay? So at the end of the year, okay, if you look at weight loss greater than 5%, or 2.5% to 5%, 1/3 of the patients actually lost weight. Okay? Half of the patients didn't lose any weight. And then 20% of the patients gained weight. So this was felt to be something that could be instituted in a very healthcare conscious group, Scandinavia. And in fact, these data don't look so good to me, okay? Now, if you lose weight, same thing came out. It works, okay? So here are the people who lost 5% of their body weight. You know, that was about 20% of people. The hazard ratio for developing diabetes, 0.31. There was a 69% decrease, just like I showed you in the UK PDS. If you lost between 2.5% to 5% of your body weight, it was a 28% decrease. Hazard ratio is 72%. If you didn't lose any weight, they set that as 1. If you gain weight, the hazard ratio is above 1. So this study is virtually identical to what we saw in the diabetes prevention program. Okay, a lot of people didn't lose weight, but if you lost weight, it worked. Okay, the big problem is how to get people to lose weight and keep it off. And this is a very telltale story. Even though rimonabant did not get approved in the U.S., to me, this tells you that unless you have some kind of pharmacologic therapy on board, I'll come by and each back and explain to you why that must happen. And diet, exercise, and behavioral modification is going to fail in the majority of patients. And in this study, the people were placed either on diet was about 500-600 calories restriction and placebo, or they were replaced on rimonabant. Okay? So the subjects don't know what they're getting. You can see the people on rimonabant are losing about 9% of their body weight. This is very, very impressive. It would have got the drug approved for a weight loss, except it had some side effects. Okay? Now, unbeknownst to the patients, about halfway through the study, half the people were split, continued on the rimonabant, and the other half continued on the placebo. But the patients didn't know that this was happening. Okay? So they're doing damn well in the first year. Okay? So now all of a sudden, You get switched to the placebo, and look what happens. You gain all the weight back. Okay? So to me, this tells the whole story. There's something that's changed in the central nervous system, okay? And that you can block what's changed with a pharmacologic intervention. But once you take the pharmacological intervention, the change that's occurred comes back. And then you gain back all of the weight over the next year. Okay? So what is the change? Okay? So when I gave the venting lecture, it was titled From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. Okay? So I'm going to create for you an ominous octet for obesity and weight loss. Okay? Just as diabetes is not a simple disease and there are multiple abnormalities, in obesity there are many, many physiologic, very powerful physiologic changes that occur that are going to work against you in terms of losing weight. So everybody in this room has probably tried to lose weight at some time, and you're pretty good for 2 or 3 months, and then you come back to, quote, this set point. Then you lose weight again, you come back to the set point. You lose weight, you come back to where you started. The bad thing about this is that with age, the set point tends to go up a little bit. So when you're 30, you lose weight, you come back to you're pretty much your same body weight. You're 40, you lose weight, you come back, oh, now you're a kilo or 2 heavier than where you were. And when you're 50, you lose weight, now you come back, you're 1 or 2 kilos higher than where you were. So this group got the idea that, look, if I can really get you to lose weight, and I keep it off at the end of the year, I can reset your set point. And so now you lose weight, and you'll keep it off, and you won't come back to that higher set point. So this is published in the New England Journal of Medicine. I suggest you all read this, because it explains why, very clearly, you are not going to succeed with diet and exercise. So they took 50 obese, non-diabetic subjects, and you can see their BMI is about 35, 50% body fat. So they instituted a weight loss program with a very low energy intake, and they're going to maintain it for 62 weeks. So the initial weight loss was 13.5 kilos, which is darn impressive. So you can see here's the weight loss. And then over the next 50 weeks or so, there's a little bit of weight gain. They gain back about 2.5 to 3 kilos. So you can see, even though that this program is pretty intensive, they still gain back a little bit of weight. So what did they notice? Okay. So first, I already pointed this out, is gradual weight gain. But still, at the end of 62 weeks, they still lost about 10 kilos, which is very nice. First thing they noted is that when you lose weight, your BMR, your resting metabolic energy expenditure goes down. Well, the resting metabolic rate went down way out of proportion to the amount of weight that they lost. So that means, and the resting metabolic rate is the major source of calories that you burn up during the course of the day. So that's working again. And then they had all of these psychological tests. These people were starving to death. Every questionnaire that they gave them, and there were like 10 questionnaires, these people just wanted to go out and kill a cow and eat it, okay? So they didn't lose this urge to eat, okay? And everything that tasted good tasted even better to them, okay? So everything was going in the wrong direction, okay? Then there are all these powerful hormones that shut off your appetite, okay? Leptin. Leptin, turns out, went down, okay? PYY, it went down. Amylin, it went down. Insulin, which is an anorectic hormone, it went down. Cholecystokinin, it went down. GLP-1, it went down, okay? And then, in addition, we know that obesity is associated in weight loss with low dopamine levels and altered CNS sympathetic and serotonin levels. All of them working against you. So here's the ominous octet for obesity. Okay? How, in your mind, are you going to overcome all these physiologic factors? You don't have a chance. Okay? So maybe 10% of people are psychologically powerful enough that they can overcome all these physiologic changes. Okay? Whereas I can give you a rimonabant, and it antagonizes all of these things, and you saw how effective the rimonabant was. And then what stimulates your appetite? Ghrelin, and the ghrelin levels are high. Okay? And GIP levels enhance energy storage in fat. The GIP levels are high. So every hormone in your body that you want to look at is working against you. And in fact, what they showed is you couldn't reset the set point, okay? And as they followed these people up out of the program, they very rapidly gained back all of them. So this is the realistic part of the story with regards to lifestyle intervention. And if you think anything else, you are totally delusional, okay? And even the obesity people have now recognized this. So if you talk to George Bray or say PCA, etc., they'll tell you that you need to have some medication on board with the weight loss program to block these changes that are going to occur. Now what about pharmacologic therapy? It works in preventing progression of prediabetes to diabetes. So there are 3 studies with metformin. This is the number of patients, the interventions metformin, duration, okay, the incidence of diabetes in the control population as you go from prediabetes to diabetes, and then the relative risk reduction. So if you're in China and you get metformin, it works wonderfully. If you're anywhere else in the world, I guess we don't respond like Chinese people, okay? So I think that the one outlying study is this Chinese study. So this is the Indian diabetes prevention program. This is the diabetes prevention program in the U.S. The most impressive data are with the thiazolidine diamonds. So troglitazone and the DPP, tripod study, Dr. Buchanan's study with troglitazone, the DREAM study with rosiglitazone, tripod study is Buchanan's study with pioglitazone, and our study with APMAP. And if you go across and read to the far right, the reductions are 75%, 55%, 60, 62, 72% reduction in the conversion rate of IGT to type 2 diabetes. Very consistent, okay, and very, very powerful reductions. We also have 2 studies with alpha-glucosidase inhibitors, stopnidem with arquebus, and voglibose in Japanese. And interestingly, there are only 2 countries in the world where any drug is approved for the treatment of prediabetes. Voglibose in Japan and arquebus in China. So it's all in the Orient. And I suspect that these drugs work very well there because they're on a very high carbohydrate rice-type diet. Very different from the kind of diet that we're on. And then lastly, orlistat, Xenical, in the Zendo study, also decreased the conversion rate by about 30 to 40%. Okay? So why do the TZDs work? So these are 8 long-term prospective studies carried out with thiazolidine diets that have been published in the literature. And by long-term, they all were carried out for 2 years or longer. And it really doesn't make a difference whether it's pioglitazone or rosiglitazone. What you see is the initial drop may differ because the study designs are very different. But whatever the initial drop is, these curves are flat. Okay? Once you drop the A1C, it stays there. The disease doesn't progress. And you can see with rosiglitazone in yellow, that's the adopt study. For 5 years, there's basically no change in the A1C. So TZDs work. Why do they work? Okay, why do they give you this very flat picture? No progression. Okay? Now that Barbara has come into the room, okay, I saved this comment for her. If she were in charge of all these lifestyle programs, maybe we could get 60% reduction on a long-term basis. So she's the general. She's the only one I know who can effectively get people to lose weight and keep it off on a long-term basis. Okay? So why does this work? So TZDs are great insulin sensitizing drugs. So these are, over the years, we've had the opportunity to use the insulin clamp. You infuse insulin, and then using radioisotopes, I can measure how much glucose is being metabolized. This is before, and then in orange and green, after treatment of rosiglitazone or pioglitazone, and you get a 35 to 40% improvement in insulin sensitivity. But the major reason why the people progress from prediabetes to diabetes is because their beta cells fail. So even though we knew this, we surmised that there must be a major effect on the beta cell. So Amalia Gastidelli and Amalia is sitting here in the audience, carried out a study to look at the effect of both pioglitazone and rosiglitazone on people who are drug naive, first 3 sets of ours, and then people who had the disease for a longer period of time are on a sheet. And we truly use the gold standard for beta cell function. So what is that gold standard? Well, why do you release insulin? There must be a rise in glucose. And then, in response to the rise in glucose, you're going to release insulin. We measure C-peptide because that's a better measure. So this is the increment in insulin secretory rate, all factored by the rise in glucose during the OGDT. But then we also know the beta cell can recognize how insulin resistant you are, and it will adjust its secretion of insulin to offset the insulin resistance. So if you're very insulin resistant, the beta cell will secrete a lot of insulin. If you're very insulin sensitive, it ain't going to secrete much because you don't that much you become hyperglycemic. So this is the gold standard for beta cell function. If you're drug naive, I have placebo, nothing happens. If you're drug naive, I have pioglitazone or rosiglitazone, huge improvement in beta cell function. And we said, look, well, what if you had your disease for a long period of time and you're already on therapy with a cell phone here, and I have placebo, nothing happens, and I have pioglitazone, you're seeing improvement in beta cell function. So the real reason why these drugs work, the TZDs, is because they improve insulin sensitivity. So insulin beta cell function, not because they improve insulin sensitivity. So how do they work? Well, the beta cell there are PPAR gamma receptors, and the direct activation of these PPAR gamma receptors changes a lot of the genes within the cell that preserve beta cell health, including one very important one called PBX. Okay? If you ameliorate the insulin resistance, your beta cell doesn't have to work so hard. And on a long-term basis, this is going to save beta cell function. TZDs inhibit lipolysis. They markedly lower the FFA. Why is that important? Chronically elevated FFA actually inhibit beta cell function, and on a long-term basis actually kills your beta cells. And they mobilize, there are a bunch of toxic lipid metabolites that build up in beta cells, fatty acyl-CoA, diacylglycerol, ceramides. The TZDs enhance the oxidation of fat, and so you lower the level of these toxic metabolites, and you get a major improvement in beta cell function. So here are those TZD studies. Tripod, 52% decrease in the conversion rate of IgT to diabetes. Pipod, 62%. Dream with rosiglitazone, 62%. The one I'm going to review with you now, ACTNOW, about a 7% decrease. So the ACTNOW study, ACTNOW stands for Actos Now for prevention of type 2 diabetes. So in this study, we, in the sample size calculation, came up with the fact that we would have to recruit 600 patients, half randomized to pioglitazone, half randomized to placebo. And to do that, we screened 1,850 people to come up with the 600 people that we needed. And then the people were randomly divided, half on pioglitazone, half on placebo. So what happened over 3 years? Here's the annual conversion rate in the placebo group, 7.6% per year. And then in the pioglitazone group, 2.1% per year. The hazard ratio is 0.28. What that says is there's this 72% decrease in the conversion rate of IgT to type 2 diabetes. These are the best data that are in the literature. This is the most effective therapy that you can give. Until, I'm going to show you something new, okay? There is something that's better, okay? But for all practical purposes, you don't know about it, it's not published yet, okay? So how many subjects with IgT do you need to treat to prevent one case of diabetes? 18. So what the hell is this number needed to treat mean? Probably nothing to anybody here. But I think everybody in this room believes that all diabetics should be on a statin, okay? Number of diabetics you need to treat with a statin to prevent one myocardial infarction, 45. Many big studies. So having an MI is not good. Developing diabetes is also not good. So why do we think it's so great that if we treat 45 people with a statin, we can prevent one MI? And that's better than treating 18 people with prediabetes to prevent one case of diabetes. To me, this therapy is more effective than prevention of myocardial infarction with a statin. Yet we don't do it on a regular basis. In addition, in ACTNOW, we measured carotid intramedullary thickness as an index of atherosclerosis. And you can see with pioglitazone versus placebo, there's a marked reduction and the carotid interval medial thickness. So this was an added benefit of the pioglitazone. Now, why did pioglitazone protect you from developing diabetes? So on the bottom, what I've plotted is the insulin secretion to insulin resistance index. This is the increment in C-peptide divided by the increment in glucose, factored by how insulin resistant you are. So this is the gold standard of beta cell function. And then I plotted here the incidence of diabetes. Okay? So in this study, if your beta cell function improved with above from 0 to above, almost nobody developed type 2 diabetes. On the other hand, if your beta cell function declined, you see you're in trouble. At the worst, 12%. And you can see the marked increase in the incidence of diabetes. So who are the people in yellow? They're all the people with pioglitazone. Who are the people in orange? They're primarily the people in the placebo group. So this just, I think, further emphasizes what I told you earlier. The critical factor is prevention of beta cell failure, and if you can do that, you can prevent the progression of IGT to diabetes. Now, more recently, there's a study that came out of Canada. It's called the CANOE study. And in the CANOE study, they looked at Canadian Indians, okay? There were 207 of them, and this study went on for 3.9 years. And what they did is use very low dose rosiglitazone and a very low dose metformin, only a gram and 2 grams of the rosiglitazone, okay? And what they found is using this low dose of rosiglitazone in metformin, that the hazard ratio is 0.31, 69% decrease in the conversion rate of IGT to diabetes. Very similar to what I showed you with pioglitazone alone. Now, with pioglitazone, we went up to 45 milligrams, and some people got fluid retention, low heart failure, weight gain, etc. Here, 0 side effects. So, based on this study, if I were to do Apnell again, I would use pioglitazone, because rosiglitazone really is not available, with low doses of metformin, okay? Now, the other class of drugs, which has the potential to prevent the progression of prediabetes to diabetes, are the incretin hormones. So, what are the incretin hormones, and what do they do? So when you eat a meal, you always release 2 to 3 times as much insulin as if I gave you the glucose intravenously to simulate the glucose tolerance curve profile. And that increase in insulin is due to 2 factors. Gastric inhibitory polypeptide, also called glucose independent insulin polypeptide, and glucagon-like peptide 1, GLP-1. Okay? GIP comes from the K cells in the early part of the duodenum. GLP-1 comes from L cells down here in the colon. So when you eat the meal, within 2 minutes, both GIP and GLP-1 go up. But they don't cause an increase in insulin secretion unless your blood sugar goes up. So as your blood sugar goes up, these hormones are around. It takes about 15 minutes for the stomach to start emptying food. So GIP and GLP are up within 2 minutes. Food comes in 15 minutes later, boom, they kick out insulin. The glucose comes back to normal, you start releasing GIP and GLP-1. So these drugs don't cause hypoglycemia. And even if I gave them to myself, and I have, and I'm not diabetic, I don't get hypoglycemia. Okay? What else? GLP-1 suppresses glucagon, GIP doesn't. There may be some beneficial effects on the cardiac system. GLP-1 shuts off your appetite, and these people lose weight. And it also delays gastric emptying, so the food doesn't come in as fast, the glucose doesn't rise as fast, and now your beta cell has a chance to get the insulin out and match it with the food in. So this has a lot of, this class of drugs has a lot of potential benefits. In diabetics, they effectively reduce A1C. As I will show you, they preserve beta cell function. That's why this is the other class of drugs which I think we should be using. They also promote weight loss. They correct a lot of the pathophysiological disturbances. They don't cause hypoglycemia, so they're safe. And they have a really quite good safety profile. So, how do we know that they preserve beta cell function? So this is a study that was done by Bunk and Heine. I'm going to show you the 1-year data, but they carried the study out for 3 years, and the 3-year data are identical to the 1-year data. So they took 59 type 2 diabetics, they were overweight, A1C is 7.5, and they're all on metformin over, okay? And they're randomized into exenatide or glargine. So why did they randomize the people to glargine? Why didn't they just put them on placebo? If I lower your glucose, which the exenatide will do, high glucose poisons your beta cell. So if I lower the glucose, just by lowering your glucose, I'm going to improve beta cell function. So they wanted to know how much of the benefit on the beta cell was actually due to the exenatide and not just due to lower the glucose. The way to have it control then is to give insulin and lower the glucose to the same extent as with exenatide. Insulin has no direct effect on the beta cell. Now we'll see how much direct effect the exenatide has. The difference between the two. They lowered the A1C to the exact same amount, 6.8 in both groups. And then they followed the people for 1 year, and they did a hyperglycemic plant. They're going to raise the glucose, and they're going to plant it. And they raised it to 15 millimolar. So you can multiply that, so 90 milligram per deciliter is 5 millimolar. So if you multiply 90 by 3, you get 15 millimolar and 270 milligram per deciliter, to which they raised the glucose to. So what happened? So at the end of the year, when you raise the glucose intravenously, when you clamp it, that's the green here, there's first phase secretion. This is characteristically lost in diabetics. It's now completely normal. Insulin, glargine, doesn't restore this, even though we lower the glucose at the same amount. And the amount of insulin that comes out is clearly markedly increased. Okay? Now, they also, at the beginning of the study, did the same type of hyperglycemic plan. And they have now repeated it 1 year later. So we're going to look at how much insulin comes out 1 year later compared before they got any drug, okay? So with insulin, the ratio is 1.31. You do make more insulin, 31% more. With exenatide, the ratio is 3.19, 319%. This is the benefit you get from removing glucose or lowering it. This is the benefit you get from lowering glucose in the exenatide. The difference between the two, take 31%, you get about a 280, 290% improvement in beta cell function. This is incredibly dramatic, okay? Now, this study, as I said, was carried out for 3 years, and the results at 3 years are identical. So what's the bad part of the story? They stopped the drug, and within 1 week, all the effect on beta cell function was lost. Okay? So that's good for the pharmaceutical companies, because you guys stay on the drug.
Yeah.
At $300 a month, you know, they love you, all right? But it's also good if you can afford it for the patient, because it means your diabetes is not going to progress. Now, this is the most dramatic study that's been carried out in the diabetes literature, in my opinion, in the last decade or so. So this is a different way of looking at beta cell function. It's called the graded glucose infusion of Polanski. So what we're going to do is we're going to plug in an IV, and we're going to infuse glucose, and we're going to raise your glucose from baseline to up to 250. And when you do that, if I measure insulin secretory rate from C-peptide, you can see this is what happens in normal controls. The characteristic lesion in people with type 2 diabetes is that their beta cell is blind to glucose. So when you do the same study now in orange, and I raise the glucose, what you see is the slope of that line is markedly reduced, okay, in green. So you can see that they release this slope much less than this. Now they're going to take these people back, and they're going to give them liraglutide, it's Victoza, okay? The previous study was done with exenatide, Valina. And they're going to give these people 0.75 microgram per kilogram body weight. So in San Antonio, a slim person in our diabetes clinic will probably go 100 kilos. So if you take 100 and multiply it by 0.7 microgram per kilo, you're looking at 0.7 milligrams. What's the starting dose of Victoza? 0.6. And then what do? You go to 1.2. Then what do? You go 1.8. So they're giving 0.75 milligrams, okay? 8 hours before we repeat the study. And a miracle happens. you have a perfectly normal beta cell in 8 hours. The bad part of the story, I stopped the drug after 3 years, in 24 hours the effect is gone. So this is not due to turning genes on and off. Okay? When you turn a gene on, it stays turned on for a long time. There's probably some ion channel effect. It really has not been studied very well. So, are there any now clinical data if we look at pre-diabetic individuals? So this is a study that was carried out by Arnie Astra in Europe, in which they looked at obese people, and they're looking at Victoza, liraglutide, as an indication for treatment of obesity. Okay? 1/3 of the people in this study had pre-diabetes, and about 1/3 had the metabolic syndrome. So there's a run-in period, then there's 20 weeks of active treatment with a low caloric intake on either placebo or liraglutide, and then there's an extension for 2 years. So what happened in this study? Okay? Well, you can see that 61% of the people lost greater than 5% of their body weight. 20%, 19% lost 10% or more of their body weight. So what happened to pre-diabetes? And 90% of them, not did they not go to diabetes, they went back to normal glucose tolerance. That's an incredible result, okay? If you look at the metabolic syndrome, it disappeared in 60% of them, okay? Blood pressure fell by 6/4 millimeters of mercury, and even though they had a normal A1C, it still dropped by 0.14 to 2.24. Now, this study was then carried out for 2 years. So, this is time 0, and we're going to look at weight loss here. This is placebo. This is this is 1.2. This is 1.8. This is 2.4 milligrams, and this is 3 milligrams. Nice dose response in terms of weight loss. So you go across here. These people have lost 12 kilograms at the end of the year. So now, at 52 weeks, if you're on placebo, you switch to the high dose of liraglutide. All of these people now are switched over to the 3 milligram dose. And you see at the end of 2 years, you come back across, they've lost still about 10 kilos. So the drug works, and it works for a long time. And now, there are 4 studies that I just presented at the ADA. They're called the scale studies. So scale 1 is treatment of obese people with normal glucose tolerance. Scale 2 is treatment of obese people with IGT. Scale 3 is treatment of obese people with diabetes. Scale 4 is treatment of obese people with sleep apnea. Okay? So what happened was 85% of the people at the end of the year, just like in this study, went from pre-diabetes back to normal glucose tolerance. And the average weight loss was about 10%. And interestingly, they almost wiped out sleep apnea, way out of proportion to the weight loss. So there may be some interesting central effects of the drug that are also working on the respiratory center. And they're in the process now of submitting these 4 scale trials to the FDA for approval for weight loss. Remember, the drug's already approved for treatment of diabetes. Okay? So this is my take on this. What works? Diet and exercise. If you adhere to it, it's incredibly effective. This is as good as any treatment we have. Okay? Metformin, 1/2 as effective as diet and exercise. TZDs, it's proven, they work very well. The alpha-glucosidase inhibitors, they work. Okay? The GLP-1 analogs, before I walked over here, I said not proven, but now, because of the scale trials, I've changed this to proven. Now, what about cost? Okay? We look at things in terms of qualities, stupid terms that I don't understand. I'll tell you what a quality that is in a second. Okay? And we're going to look at the diabetes prevention program. This is the 10-year follow-up. Lifestyle heavy, metformin, or the placebo treatment. Okay? So what is the quality? It's the number of years that you live divided by the quality of life. And there's this quality of life questionnaire. If you're alive and healthy and you answer all the questions right, you get a 1. If you're dead, that's not good, you get a 0, okay? So they just take this scale, 0 to 1, and they multiply it by the number of years that you live, okay? And that's what equality is, and this is what all these healthcare economical people look at. You can see if you simply look at qualities, there's no difference between lifestyle heavy, metformin, and placebo. But if you look at the cost to achieve this improvement in life, okay, lifestyle is expensive. You've got to get nurses involved, dietitians involved, exercise physiologists. Metformin is costly. Okay? So, what is cost saving? Influenza vaccine. Okay? What do you all do? You treat hypertension. You treat dyslipidemia. The cost is between $10,000 and $60,000. Okay, with metformin, you actually doesn't cost you anything. You save money. It's better than treating your blood pressure and treating with a statin. Okay, and look, if you go on to dialysis, the cost of dialysis. Okay, so the other thing that bugs me about all of this is this kind of cost analysis is applied to societies. Okay, and why is it applied to societies? Because they don't have enough money to dole out for all of these drugs. And so they look at it from a societal basis, okay? And that's obviously important in many countries in the world where they can't afford the drugs, okay? But the fact is, this is not relevant to the individual. If I can afford the drug, I want to know, will this drug prevent me from developing diabetes? And if I can afford it, I will decide whether I want to be on the drug, not some stupid government system that tells me what I can do or can't do, okay? Because that's totally insane. We have freedom of choice. And we know on a long-term basis, okay, that from treatment with metformin, it's cost-saving. So why do we do it? What is the VA doing? Okay? Our government paid for the DPP study. Now we have the 10-year results of the DPP. So why? It's only $4 a month. It's dirt cheap. Okay? Why don't we do it? Because the government hasn't decided it should be done yet. Okay? But it clearly works. Okay? Now, people can say, and I hear this argument all the time, why not just wait till the person who has prediabetes develops diabetes? Well, first of all, you have that person with prediabetes, the likelihood of him coming back and following up so you make the diagnosis in a reasonable time is diminishingly small. Okay? Not all people come back for their checkups. Okay? And why not even start earlier so we can preserve beta cell function? So what we know is that the loss of beta cell function starts to occur long before you even develop prediabetes. So this is two studies that we carried out. One is called the Vegas study, which was done here in this hospital. It's called the Veterans Administration Genetic Epidemiologic Study. And the other is the San Antonio Metabolism Study. So these two studies together have 259 people with IGT, 201 diabetics, and 359 control cells. So on the on the x-axis, I plotted the 2-hour glucose. This is a measure of your glucose tolerance. On here, I plotted your beta cell function, increment in insulin, increment in glucose, factored by how insulin resistant you are. Your 2-hour glucose is less than 100. This is as good as you're ever going to get. 2-hour glucose, 100 to 120, 120 to 139. You have normal glucose tolerance. Yeah, but you lost 50% of your beta cell function as you go from perfectly normal to the upper limit of normal, based on the ADA. Now we have IGT, okay? So by the time, and I just divided these people, 140 to 160, 160 to 180, 180 to 199. You have 200, you have diabetes. You're in the upper tertile of IGT, you lost 80% of your beta cell function, and not shown on the slide, you're maximally insulin resistant. You don't have to lose much more beta cell function. You go from a 2-hour glucose that's 180 to one that's above 300. So IGT is not prediabetes. IGT is diabetes. Just the ADA doesn't recognize it because they have some funny cutoff values. Okay? You can see that beta cell failure is a continuum. It starts in the normal glucose tolerant range and it just gets worse with time. Okay? Now, what's even worse is this study by Dr. Butler, and there are 5 other studies that are in the literature. If you lose beta cell function, we have drugs, TZDs and GLP-1 receptor agonists, which will get back to beta cell function. But if you lose beta cells, there are no drug that's going to get back to your beta cell. This is studied by Dr. Butler. He's a very strange guy. He collects dead bodies. And he goes and he takes the pancreas out, and he has a special optical system developed at the NIH. And he counts the volume of the beta cells. It's not exactly counting mass, but number of beta cells, but it's reasonably nice. So we're going to plot beta cell volume, and he tried to shake these people. You know, I told you he's a strange guy. He waited up to do an OGDT. The people just didn't wake up, couldn't understand. But he can measure the fasting glucose. So there's another way that we, quote, make the diagnosis of prediabetes, and that's if your fasting glucose is between 100 and 125. Of course, you get to 126, you have diabetes. So here are the people with NGT, they're the people with IFG. According to Dr. Butler, you already lost 50% of your beta cell volume. Now, if you look at the other 5 studies, the number that people come up with is closer to 15 to 20%. And I think that's the real number. But the point is, you're already losing beta cells. And you don't have diabetes, according to the ADA. Okay? Well, what could be worse than losing beta cells? Once you lose all of them, you're on insulin. Okay? And that's what we like to prevent. And if you look at the people with diabetes, they've lost even more. Okay? Now, what's the other reason for treating at the prediabetes stage? This has to do with physician inertia. Okay? So, at Kaiser Permanente, they had very good electronic medical record. And so, when the chemistry values, the A1C comes back, it's in the chart, it's flat. Okay? They also have very good records for what goes on in the pharmacy. So they know what drugs are started on what date. So all they did is match up the A1C values when the drugs were started. So now, here comes back an A1C value greater than 8. Not greater than 7, greater than 8. Now the patient is on diet and exercise. How long in a good HMO does it take the physician to start therapy? 8.7 months. Now, you're on metformin. Here comes back the A1C. It's about 8. How long does it take the patient, the physician, to increase the dose of metformin or add another drug? 14.5 months. You're on a sulfonylurea, another worthless drug, of course, which we use all the time in the it takes 20.5 months for the physician to start another drug. And what's worse, if you're on metformin and sulfonylureas, it takes almost 26 months. Why so long? Because the next step is insulin. And in the VA, you're basically stuck with metformin. You're stuck with sulfonylurea. And the next step is insulin. If you try to get any other drug in the VA, you'll go crazy trying to get it. Okay? So people are reluctant to start on insulin. It's called physician inertia. So there are 2 very good reasons to start treating before you develop diabetes. Number 1, you're losing beta cell mass and function. And number 2, people generally don't start treating even when they make the diagnosis. So this is the last slide. So this is your typical patient. What does it say? The low caloric diet that you put me on 20 years ago gave me diabetes, hypertension, and heart disease. Because that's exactly what the low caloric diet does, because the people don't stick to the low caloric diet. Okay, the implications are that you're going to need to treat people with dietary intervention, exercise, and pharmacotherapy if you really want to be successful. So that's the last slide, and I'll try to answer any questions that people might have. Yes?
On the slide before, when you demonstrated how prediabetes is actually diabetes, I mean, it seems to me like they should be changing the diagnostic criteria for diabetes. Is that being discussed at all? Or,
Yeah.
I mean, they've changed it before,
Yeah.
in the past. So.
It has been discussed, and basically what they've concluded is that if they lower the A1C value down in the diagnostic criteria, it'll make more people with diabetes. This is the true reasoning. That means more medications to treat the diabetes, and the system can't handle the additional influx of diabetic patients and the expense and recommendation of anti-diabetic medications. But we'll pay for it if you go blind after 10 years. We'll pay for you to go on dialysis 10 years later. Okay? So to me, this is a nonsensical argument. You know, you end up on dialysis, I showed you, it's $100,000 a year. You can treat a lot of people with a lot of drugs. And if you just prevent one case of, end-stage renal failure. if you go blind, I can send you up to Austin, and you can stay up there for a month and a half at the Commission of the Blind at about $40,000. You'll get a seeing eye dog, they'll teach you how to read Braille, etc. Wouldn't it be better to prevent the blindness? And you can't even factor in the quality of life. I mean, that has no cost value. And that really aggravates me more than anything. Because if you're blind, and I actually have been blind in my life, and you realize you can't do anything. Or the things that, you know, how am I going to read the journals? How can I walk across the street? That's pretty scary. And people who are making these decisions, just, they don't have any feeling for the quality of life. And that can't be weighed into any of this. And so it bugs me that we don't have better drugs for treating diabetics, because we have drugs that will work. Unfortunately, the new ones are pretty expensive. Other questions?
Do the TZDs, sort of they work and they got such a bad rap about 10 years ago or so. Does anybody use them anymore? Are there?
Yeah. So I use them, obviously. And we use them in all of the studies that we do. And I've cut my private practice down simply because I'm involved in too many other things. But I use them as first-line therapy in my private practice. New prescriptions, I did the Novo broadcast about 4 months, and I asked them to give me a list of new prescriptions in the U.S. So some things were expected. Metformin is number one, 42%. Also expected, and disgustingly expected, sulfonylurea is at 38%, and these are truly worthless drugs. Insulin at about 43%. The whole incretin market is 13.5%. And of the incretin market, 80% is DPP-4 and 20% is GLP-1. So 20% of 13.5% is 2 or 3%. People don't use GLP-1s. Why? They're an injection. They use DPP-4s. Why? They don't work very well, but there are no side effects. Doctor won't get called on the weekend. And then pioglitazone, 4%. So it's dropped from high in the 20s down to 4% because of all of these scares. Now, for those of you, I mean, rosiglitazone is gone because of the cardiovascular scare. Although the FDA has backtracked on that, there's just no way people are going to use rosiglitazone in the U.S. And then pioglitazone, remember, there was the bladder cancer scare. Got written up in the New York Times, USA Today. So the FDA asked Takeda to do a 10-year study looking at bladder cancer. And it was done, and the 8-year data are now just published online. Again, Kaiser Permanente. The hazard ratio for bladder cancer is 0.96. It's less than 1. It's not significantly less than 1, but in it, greater than 1. Yet, this is where all of these lawsuits have gone, you know, 1-800-BAD drug, the billboards and stuff. And so once you get written up in the newspaper, you're in trouble. But TZDs are great drugs, and particularly if you don't go above 30 milligrams. You get very few of the side effects, and they work very, very well. You know, we used to have rosiglitazone, and for those of you who don't know this, when rosiglitazone went off label, or they got kicked out, I wrote a series of letters to the Washington, D.C. headquarters, a whole lot of emails, and they never responded. Finally, a year later, I don't know, a dozen or so emails, I got a response saying, oh, Dr. DeFronzo, you didn't give me your conflict of interest. So I went back and showed them in the very first email, since I know the government, I put my conflict of interest. And what they wrote back, I'll translate it. It says, Dr. DeFronzo, you're a whore for the pharmaceutical industry, and your thoughts are totally worthless, and we throw them out. That's what I was told. I only happen to be probably the #1 guy in the world in the diabetes field. And, you know, this goes on and on again. So dapagliflozin went to the FDA for approval. So what happened 1 week before, and I actually developed the SGLT2 inhibitor class of drugs. So I went through preparing all the mock advisory boards. 1 week before going to the FDA, somebody noted that I had a part-time appointment at the VA. Government employees are prevented from testifying for the FDA in behalf of a drug. So 1 week before we go to the FDA, they had to find a replacement for me. So we have all of these crazy rules and regulations that don't, in my opinion, help us, particularly to take care of people in the military. Yes?
So you said using these drugs for diabetes, I mean, they can't be used just off-label. So what is the biggest, barrier why doctors don't use them?
The biggest barrier is if something goes wrong, you're at risk from the legal standpoint, and we are a very litigious society. So if you use these, and a lot of people I know do use the drugs off-label, but it's very unlikely that primary care docs who really don't know the drugs, don't feel comfortable, don't want to get involved in lawsuits, and they're taking care of most of these patients. It's very unlikely they're going to use them. So they are used to a certain extent, but there's this legal issue that hangs over everybody, which is the major
Even with
concern.
metformin?
No, with metformin, it should be okay, but they still don't use it. So personally, you live in San Antonio, you're Hispanic, your mom has diabetes, your dad has diabetes, you come to me, I do a GGT, and your 2-hour glucose is 170, you got diabetes. I mean, if I want to wait another year, okay, you'll be above 200. I'm just going to treat you, okay? Now, you live in Boston, and you're Caucasian, no family history of diabetes, your 2-hour glucose is 142, I'm not going to treat you, I'm going to watch you, because you're not at very high risk. So you have to use some judgment. And the more risk factors, particularly family history for diabetes, and the higher your 2-hour glucose, the more likely you are to develop diabetes. We know there's a very high rate of progression, so I would treat. Okay? But that's me, that's not the primary care doc. Other questions? Okay, the sun is out. Hopefully no rain. Time to go home.
Thank you.